Evening, everyone. Thank you so much for joining us here in Kentucky on this snowy, cold winter evening for the first of our 2022 Social Justice Movie Nights. I'm Donna Meador. I'm the president of the Kentucky Nurses Association and very glad to welcome all of you to join us tonight. This should be a very, very intriguing night and a very, very special night for all of us. I really want to thank the U of L School of Nursing and the UK College of Nursing and the Frontier Nursing University for supporting this type of interactive learning. Our chair, Teresa Villaran, will probably talk a little bit about the history of these social justice movie nights, so I won't get into that, but this is our second year of doing those, and I think it will be another excellent program. This movie, I'm sure you've watched by now, The American Dream, Birth is a Dream. We are not intending, KNA is not intending to promote any particular type of birthing arrangement, but really just to share perspectives of women of color when it comes to maternal child health in our country. At that point, I will turn it over to Teresa and we'll get started with everything. Thank you all very much.
Hello, everyone, and welcome. Thank you for attending. I don't know if you know about our intersection of social justice and healthcare movie nights. We created this after everything that was going on in 2020 with all of the murders of Black men, all of the social justice demonstrations. So we've covered a lot of things, eugenics and genetics, to climate change, to even using the Medicare when it was first enacted to integrate healthcare systems. So we've talked about a whole lot of different things. Participants wanted us to continue this, so we will be continuing this quarterly, and we're starting off with our Black maternal mortality discussion. I want to introduce our panelists. I want to thank them for giving their time. First, we have Katrin Arango. She's a nursing student at Berea College. She's a birth doula and certified lactation counselor for the Healthy Children's Project. She received doula training from Johns Hopkins University and most recently has been working with birthing women in Eastern Kentucky. Dr. Lucinda Canty is assistant professor at the University of St. Joseph, West Hartford, Connecticut. She focuses on research on maternity and severe maternal morbidity, Black maternal health, and addressing racial ethnic disparities in reproductive health and addressing racism in nursing. She has a doctorate in nursing from the University of Connecticut, a Bachelor of Science in Nursing from the Columbia University School of Nursing, and nurse midwifery training from Yale University. And is Dr. Emmanuella Charisme on yet? Dr. Emmanuella, please tell us your last name.
It is Emmanuella Charisme.
Charisme.
Yes. Oh, that's so beautiful.
She is president and founder of AMA Community Health and Wellness Center and is practice manager for AMA OBGYN Associates LLC. She travels to different parts of the world several times annually to provide OBGYN medical care to reduce Black women's maternal mortality. Dr. Charisme has a Doctor of Medicine from Penn State University, College of Medicine, and a Bachelor of Arts in Chemistry from Drew University. Alicia Morgan, again, is a certified nurse midwife of Lexington Women's Health and is affiliated with Baptist Health Lexington. In addition to her clinical duties, Alicia serves as on hospital and organization committees at the state and national level, speaks on midwifery and women's health topics, and mentors new midwives and nurse practitioners. She has a Master of Science in Nurse Midwifery from the University of Cincinnati and is pursuing a DNP at Frontier University. And Dr. Connie Gail White is Deputy Commissioner for Clinical Services for the Kentucky Department of Public Health and is the medical advisor to the Kentucky Perinatal Quality Collaborative, a common table for providers, birthing hospitals, and insurers to improve the quality of maternal health in Kentucky. Dr. White is an OBGYN with more than 35 years of experience. She has Doctor of Medicine from University Kentucky College of Medicine, a Master of Science in Toxicology from UK, and a Bachelor of Science in Chemistry from Kentucky Wesleyan College. I want to thank all of you for being here. We are going to be taking questions from participants. I will be asking some questions beforehand, but make sure that if you have a question that you want to ask the panelists, that you put it in the chat, and Delanor will monitor that for us. And we can ask those questions near the end. We're going to give you plenty of time to ask your questions because that was some of the feedback in our last sessions was participants wanted to have more time asking their questions of the participants. So I look forward to you all asking your questions. Maybe we don't know, and maybe that's why we're doing the session tonight, that Black women are 3 to 4 times more likely to die of pregnancy-related complications than their white counterparts. What are some of the problems contributing to these disparities? I will start with you, Dr. Canty.
So, and I think that's a good question. And that's really what kind of started my own research. When I started looking into understanding why Black women are more likely to die, not even realizing that during my own childbirth that I was at risk, it was just amazing to me, all the technology and things that we have here. And what I was told was that women were poor. I was told that women had no access, they didn't have insurance, they were uneducated, they were unmarried. Those were all the reasons that I was told, and that they were Black, and Black was a risk factor. But what I found out through my research was that women were starting prenatal care their first trimester, attending every single prenatal appointment. They were educated. They lived in poor areas. They lived in wealthy areas. So just from my research, the bottom line is that racism is a big cause of it. It's painful to think about, but women aren't listened to, particularly Black women and other women of color. So it's very heartbreaking to know that. And when I actually started looking into this research, there was very little. I think I only found like 3 research studies from nursing. There was other professions looking at this, but they still weren't talking to women of color. They were looking at their charts, looking at birth certificates, death certificates. So my research really focused on talking to women who almost died during childbirth, who had like blood transfusions, who were in the ICU, who didn't even think they were going to survive. They just had their baby, heard their baby crying. But I found the reasons that I found in talking to women was it was lack of education about the complications. Also, how they were treated by providers. Women said that their provider had a big impact. If they had a relationship with them and they trusted them, even if they had, these complications, they still felt safe. But other women said they couldn't tell their provider. I'll give you a quick example. A woman saying that she had chest pain. It woke her up in the middle of the night. She goes to the emergency department and she's told, oh, you just have a little angina. You can go home. Go home and rest. It'll go away. On her way out, another doctor stopped her and said, and she believes her nurse went and got this doctor. This doctor said, we need to do more tests. Her heart was functioning at a 10% ejection fraction. She was told if she didn't improve in 3 months, she would need a heart transplant. 28 years old, first pregnancy, but realized that she was having symptoms as she delivered her daughter. So, but anyway, she almost went home. She said, if I went home, I wouldn't have made it. And I was made to feel like I was exaggerating, that it was in my imagination, but she was having real symptoms, but she wasn't heard. And unfortunately, as you saw in the documentary, this is very common. And this is a life or death situation. But I think listening to women, having them educated, and just having the support that they need to feel, I need to trust my body. I know my body. So those are just some, I want to hear also the other panelists, what they have to say. But it's just some of the common things that I found in the women that I talked to.
And I think a lot of what you said, we did see in the documentary. One thing that really stuck with me was one of the women said, we don't have access to knowledge that's been passed down to us from our family members like other people might have. I think that women come in and ask the right questions. One lady said that she felt like she was just a chart.
Mm-hmm. Yes. Yep.
All right, Dr. White, I want to ask you the same question, but how can we relate that to what's going on here in Kentucky? I mean, we've seen this across the country, but now how do we see what's going on in Kentucky?
Thank you for asking, Teresa. There are so many things that are happening in Kentucky. So I'm in the Kentucky Department for Public Health, 20 years of OBGYN, and then I've been in Frankfort, Kentucky, a small community. Then I've been at the cabinet for 12 years now. One thing that I'm very proud that we were able to do was to get a maternal mortality review committee that is functional. We've had one for 40 years, but it didn't have any kind of liability protection. So as you all know, that if you sit in a room and talk about a case and you don't have that protection, you're not going to get a real professional evaluation of what really happened. So in 2017, we began looking at each case individually. Some states will pick every 5th case or 10th case. If they're large states with lots of cases, we look at every single one of those cases of every woman who has died in Kentucky, regardless of the cause of death on the death certificate. And we don't go to 42 days. We go, as the World Health Organization definition is, we go to a full calendar year after the delivery, because there are so many, especially the cardiac events, that may not happen in that first short period of time. So what we're doing is we're tracking it at 42, but also at 365. So we can see how our data would be presented depending on what definition of maternal mortality you're looking at. We have a very robust committee that I'm very proud of. Our team has put together. In fact, we've presented at the CDC and people have said, now, why do you have that person on there? We have neonatologists, maternal fetal medicine specialists, generalists from the rural areas. We have a cardiologist, a women's cardiologist. We have someone from AWAN. We have someone from the community-based services for those out of state. That's where our social workers live. We have someone from Casper that gives us a report on each patient. We are blessed to have a certified nurse midwife on our committee. We have someone from the Hospital Association. We have our chief medical examiner is at every meeting and explains the autopsies. We have someone from the human trafficking unit at the Office of the Attorney General. We have Dr. Alan Brenzel, who helps us. He is a psychiatrist, a child psychiatrist, and a pediatrician. He helps us with looking at the substance use disorder cases. We have someone from Kentucky State Police and Medicaid Services. So we have a really lots of different eyes looking at every case with a different lens as we evaluate this. And there's a form that we fill out that the CDC has given us that goes through we collect the same data on every single person so that we can have something we can compare to. And then in the end, there is the recommendations. Was this preventable? And if it was preventable, what things could be put into place to prevent it from happening again? That's the one group, and the other group is the quality collaborative that's going to be looking at those recommendations going forward. So a lot of activity happening in this critically important area.
Great, excellent, yeah. One thing that kind of stood out to me also in the documentary was one of the women heard someone say, that's another one with a gold card, talking about someone who has Medicaid. And so those little microaggressions, I think, are what make women, particularly Black women and women of color, not trust healthcare professionals. Alicia, I wanted to talk to you. You're a certified nurse midwife. What are you seeing in your practice that is impacting, or what are you doing that might help to alleviate some of this disparities that we're seeing?
Well, one of the great things that I'm involved in is the Institute for Medicaid Innovation. They have right now that Kentucky is one of 5 states that have learning collaboratives so that we're trying to increase midwifery care for Medicaid moms. And so it really does have aspect to it addressing racial disparities and really trying to get midwifery care out to underserved populations in Kentucky.
Great. Excellent. Dr. Charisme, what would you like to add?
I was trained as an OBGYN physician. I've been to the situation where I was the near-death patient. I was pregnant when I was in medical school, and it was a no-no. It was a taboo, and everybody was very upset about it. And I miscarried that first pregnancy, and people were relieved by it. And so later on, I prepared myself to have a better outcome. So I had to learn it by myself, just like everyone was saying that you don't have any education about what's going on. It was my first marriage, my first pregnancy, everything's the first, and you are in this micro environment where nobody's helping you with anything. So I was at that phase. While I was in medical school doing a residency, doing a rotation in OBGYN, I was pregnant with my, first live born child. And I was being used as an example for everything that was going on with anybody, because unless I tell you that I'm pregnant, you couldn't tell that I was pregnant, because I was having so much problem with the pregnancy that it was very stressful. And then being used as an example was not good for my, mental health. But I went through, I'm a strong person. If I tell you about my life, you would understand. But I got through it. I was in the same situation where when the place I was going for care, it was a lot of different doctors I was being introduced to. I later understand what's going on, now that I'm an OBGYN, so I can explain it to other patients. But when you are there in the position, you don't understand. So all these different doctors, all it is because they try to introduce you to all the doctors so that if anybody's on call, when you go into labor, you would have met that person. You might not know the person, but you would have met that person at one point during your pregnancy. That's the only reason that they do it that way, which is not a good way, but that's the way it's done. When I delivered, my Pitocin was turned off. It was put in at half a liter, and then it was turned off by the nurse when I was brought into the room. I passed out in the bathroom with postpartum hemorrhage. My hemoglobin was less than 5. And so I was at that stage where I could have died. And I don't know, there is some phase of it where it's about respect, because everybody was shocked that I was a medical student and I'm studying as I was in labor. And so, things are happening to you because you are in healthcare. So that could be a phase. But as many of you realize, it doesn't matter if you're poor or rich. Whatever happens to you, it's your own experience, and it depends on who's taking care of you and what happened that day. It's just like if reading something and everybody could find, like if you read a parable, everybody can see different meaning in it. It's the same way. When you go into labor, when you're having that experience, it's your own experience. And people have to be vigilant, just like that patient who had the cardiac issue. If somebody was not vigilant to look into and making sure that she was taken care of, she would have gone home and died. Mm-hmm. And many that happens to. So there's a lot more that's going on. Respect is part of it. Racism is part of it. But there's a lot more that can be done, that should be done. The reason I wanted to be in this panel is a lot of people believe, they have to be taken care of by a midwife so that they could have proper care, or be in a birthing center for them to have proper care. But it's not necessary. You can have the proper care. You don't need to have a specific knowledge to do it. Like, for example, with my second pregnancy, I did not get care from anybody. I provided my own prenatal care. The reason I did that is because I did not want that same experience. I did not want 10 doctors to see me with every visit. I went and got a pap smear the first visit, and I did not like the way she treated me. She acted like I was the dumbest person in the world, even though she knew I'm another physician, another OBGYN, just like her. She's doing a pap smear on me, and I told her, do not just use the spatula. You will not get any cells. I'm pregnant. Use the brush. You cannot use the broom. You rupture my membrane, but get cells. Do a proper pap smear. She did not. And then she called me and wanted me to come back to repeat the pap smear because the pap smear came back abnormal because there's no cell. And I told her, I will never come back to you because you did not give me proper care. And people have to speak up. You have to know the way you are treated, if you treat it correctly or not, and you have to speak up. Yes, they're going to treat you and they're going to label you. That's okay. Make a list of your questions and come with every visit with your question and ask them, why is it that there's so many different people taking care of me? Why is that? Why can't I have one person take care of me? Yes, in labor, I might come in the middle of the night and somebody else might be there, but I might end up delivering during the day and you may be my only doctor that should come in. So why can't one person take care of me? You can ask that. So I like to empower people and educate people. And that's what I do in my practice. When I try to help, I believe people should start preparing for pregnancy months before they become pregnant so that they can be ready, be educated, and be more empowered during the pregnancy.
And I think those terms are, we heard those a lot in the documentary, where women felt disrespected. All they wanted to do was be treated the same and equal. But a lot of times they talked about being empowered to make their own decisions. But I want to talk about some things that may impact the experiences. You know, one of the women, her concerns were that she didn't feel safe. She was afraid of not being safe. She was afraid of financial problems and not having anyone at her side, you know, when she was giving birth. So those are real concerns and fears. I want to talk with you, Katrin, as a doula. That is an alternative option for women. You tell me, you know, what the role of a doula is and how you might alleviate some of the fears that a pregnant woman would have.
Thank you. Yes. So I am a birth doula, and the kind of blanket definition is we provide emotional, educational, and physical support to birthing women and their partners or whoever they're birthing with. This can, I know some people think it's like, oh, all midwifery model care, kind of hippies that have birth doulas, but we serve in all kinds of capacities there. You know, I have been able to work with moms that have had C-sections as their birth doula, but, you know, what I think a doula, yeah, every doula practices differently. And I think that that's very important to say. Not every birth doula is the same. And you don't need to have a medical background to become a birth doula. And, you know, I am a nursing student, so I do have some of that background. I trained with social workers. I trained with just stay-at-home moms that had a particular birth experience and then became passionate about it. And so really, we are just people that get to know the person that's going to give birth during the pregnancy. And we don't worry about the blood pressure or the size of the fetus or any of that. I do sometimes like to ask about, hey, how's the health status? Like, how are you eating? Like, I like to ask those kinds of questions because I know it's important. But my main question as a doula is, who are you? What is important to you? What makes you feel comfortable? How do you deal with pain? Like, if you've never had a baby before, how do you deal with this normally? What are your beliefs? Like, I do ask, like, do you have spiritual beliefs? Do you have rituals that are important to you? I want to get to know those things about you so that we can see how we can incorporate those things into your birth experience, whether it's at a hospital or at home or at a birthing center, because we can't, you know, make everything happen that they want in their birth plan. But if we get to know what are the things that are really important to them, we can do what we can creatively to incorporate that. And then advocacy. So once they've told us what is a value that they have that is important to them, that we are able to recognize when that is not being respected in that birthing space. So I had a mother, I am Latina. I had a mother who was Latina as well. I love working with minority women, although I've worked with all kinds of women, but she was very special because she was Latina, but she also was Muslim, which is not a very common combination for people. She also happened to be, you know, darker skin tone and first generation immigrant. So there were so many different things at play here. And I asked her, you know, what is important to you? Are there any rituals or prayers or anything like that? And she said, you know, it really calms me down when I listen to the Quran, just an audiobook, right? Okay, great. That's important for me to know, so that if that's something that can relax you, make you feel safe, let's do it. We can put some, you know, some headphones in, and I don't make assumptions, right? Just because she's Latina doesn't mean she has a specific kind of faith background, right? Or anyway, so when a provider oversteps, in my practice, I don't come in and say, hey, like, she doesn't like that, you know, or like, I'm not that kind of person. But what I see myself in terms of advocacy is I will say something like, you know, this is really important to Jane, and I'm not sure that she feels comfortable with the way that you are doing X, Y, or Z. And I'm facilitating that when she may not be able to recognize that that boundary is being crossed. And same with partners. If partners, with COVID, I haven't always been able to attend the birth in person. So I do a lot of coaching over the phone. They will text me 24/7 during labor. Partners, I communicate very heavily with partners, and I try to practice with them. Hey, how would you have this conversation if the provider is doing something that she does not feel comfortable with? And in a non-aggressive way, but in a way that the birthing person knows that they are being respected, and the birthing partner knows that they're not overstepping their bounds by saying what needs to be said, so that the birth environment is adequate for mom. That's a lot. Sorry.
That's great though. I think the advocacy part is really good. It shows that you got to know this birthing person, and you're just there saying, look, this is what she's comfortable with and what she's not comfortable with. I think that's great. I think they all need advocates. Mm-hmm.
Yes, and I want to say something because Katrin, what you said was so important. You see them as human beings. You see them as people who are women, who are going to be mothers, if they're not already mothers, who are partners. And I think that's what the key is here when we're looking at Black maternal health, or just health of any woman, but particularly women of color, is that we have to be seen as human. And when someone is coming in for childbirth, they're in their most vulnerable state. And a lot of times we come into the system relying and trusting, but if someone doesn't see us as human, they're going to treat us any kind of way. And you do want to be able to speak up, but when you're having contractions, when you're pushing, when you're postpartum, you need a healthcare provider. And again, it could be a midwife, it could be an OB, but again, they have to see the person as human. And unfortunately, in this country, women of color have not had control over their bodies. They're not believed. Look at pain. When women say they're in pain, they're not believed. And sometimes there's something so serious under that. And we know also when someone does die, particularly a Black woman or another woman of color, she's blamed because we're not believed in what's going on with us. And when things go wrong, it's because of something we didn't do. But we could start prenatal care early. We could prepare. We could do preconception care. We can come to every appointment, every ultrasound, prenatal vitamins, walk, eat right. You could be Serena Williams and you could die in this country. It doesn't matter how much money you make. And that's a concern, that someone coming in that's trusting the system and the system's not there for them. So we really have to look at those pieces. But Katrin, what you said, it doesn't cost any money to do. Just treat people as human beings.
Yep.
Pretend that's your mother, your sister, your wife. How do you want them treated, and treat them that way? And unfortunately, there's no accountability when things do go wrong or someone's not listened to. And that's why this continues to persist. And this is going to continue to be a problem unless we really look at those pieces and we stop blaming the women.
I would like to mention something really quick. So I kind of explained what the role of a doula is, and to speak to what you're saying, Dr. Canty, and it's something that Teresa and I also spoke about before, is, as a provider, I guess now I'm speaking from the nursing side, it's very hard to get to know somebody in such a little amount of time, whether it's prenatal appointments or, just as they're coming in to the labor and delivery hall, or what it might be. It's a very short amount of time, and it's very hard to really get to know somebody, and it's acceptable. It makes sense. We don't have the time as providers to really get to know who you are. We look at your chart. That's just the reality of working in what we do. In terms of how can having a doula be part of the team, I think it's from the provider side, and I guess it's kind of weird because I'm also in nursing, but I've also seen the doula side, so I kind of see this weird space to see a doula as part of the team. Mom is the top, she's the center of the attention, but for the provider to respect the doula, not because of her degree or whatever, the fact that she knows this mom enough and knows enough about birth and labor to advocate for that mother's desires. And so to work as a team and to have respect for each other one of the things that I tell the birth partner when I start working with the mom, because most of the time people don't know what a doula is. I say, I am not going to replace you as a birth partner. You know mom and I know birth, and we work together to make this the best experience we can under whatever circumstances that might be. Even if it's an emergency C-section, like we're gonna do the best that we can, but we're a team. And as a team, we also have to work with the providers, the OBs, the nurses on the floor. And sometimes that's not always reciprocated. And sometimes it's because I've heard nurses like, oh, I've been burned by some doulas because, they were rude or whatever. And I get that. But that doesn't mean that doulas shouldn't be a part of it, or should be encouraged in that space.
That's good. That's great. Thank you for that. I want to know, how do social determinants of health fit into this public health crisis? And Dr. White, I'd like to start with you.
We don't have a lot of data to give you good, solid p-values and all that stuff, but I can give you the broad strokes of what we're looking at. We're looking at over 2017, 2018, we had 11 women of color who died in Kentucky. We've got everything, and I tried to divide this up. Of those 11, 5 of them were substance use related disorder deaths. Over 52 to 53% of Kentucky deaths for women are substance use disorder factors, whether it's an overdose or whether it's they have a valve problem from the IV drug use they had in the past that damaged a valve, and then they have a cardiac event while they're pregnant. Half of the women of those 11 women died while they were pregnant. The other died at 42 days or more after delivery. The thing that struck me is the number of women, and I don't have a firm number on that tonight, but the number of women that when DCBS looks into their file to give us kind of a flavor of what's happened in this woman's life, so many of them were in the system when they were children. So they were trafficked as children, or they were sold drugs or given drugs by their grandparents, foster parents, whoever, Uncle George. We see a lot of people that are in the system, not very much, but a little bit of law enforcement involvement, lots of domestic violence, which cannot be a shocker to anybody. We're looking at 2019. Of those, there are 6 women of color. 3 of them one's a suicide, a homicide, substance use disorder, and the other 3 are medical. And looking at the medicals, there's a hypertensive case. And I know we had one woman talking about social determinants of health. Her blood pressure was up. They kept her in the hospital extra days. Her pressure was still up. And they said, we want to keep you. And she said, I've got other kids. I've got to go home. And she went home and died. That one just absolutely broke they all break your heart. We had amniotic fluid embolism. We had 2 women with cancer, which I found that very unusual for that small of a number. So it's a broad range of things. And as we get more and more numbers of these in-depth analysis, we can have something solid to work on. But like I said, each individual one of those cases has a recommendation. And we're going to take those recommendations and say, is there a policy in place that could prevent this? And if there's not, how can we make one happen? If there's a policy in place that's not working, how can we make that policy work? So that's something that we're working very hard on.
Great. Excellent. Dr. Charisme, what about you? What do you see as the social determinants that are affecting this public health crisis?
I think there's different factors. Just like it takes the village, I think it will take a lot more. I can give you some examples. Always prefer getting care or recommend care at places where there's residents, because there's a lot more eye to be around, more nurses, more providers. It's not just doctors you see, there's midwives there, there's PAs, nurse practitioners. So you have a full flavor. But you still have to find a way to get everybody on board to see the village, to try to give each person a best outcome. So I've had good experiences as a resident and some bad experiences, and it depends on the state of where you are. New York, it's the worst outcome that I've had. Pennsylvania is better. New Jersey, I think, is in the middle. I've done poster presentations where I show advanced obstetric emergencies so that during the time where there's an emergency on labor and delivery, what to do so that the doctors can know what to do. But those classes are not being taught to OBGYN physicians. They are being taught to family practice doctors who does OB. And a lot of OBGYN residency programs don't want to learn this kind of emergencies. But it's just like BLS, ACLS, that it's mandatory. I think a program like that is necessary for every doctor. Just like if you renew your BLS, you should renew ACL. It's called ALSO, which is Advanced Obstetric Emergencies. I think a lot of training can be done and make a difference in a lot of, because it's not just the respect, it's not just the listening to, it's a lot more. When things start going wrong, like if you ever in a mortality conference, because I usually talk with the patients or the family, things started going wrong from home. It didn't start going wrong at the hospital. It started going wrong at home. And a lot of people miss that. I've had patients who was having a simple abortion. And the first thing that happened is that the partner who was supposed to take her to the hospital bailed out on her. Then she decided not to make the appointment. And then she goes and get a back alley appointment, had a back alley abortion because she couldn't make the appointment that she had at the hospital. And she became infected, went to the hospital and died. And we're talking about an 18-year-old that died because she did not get care properly.
Didn't have the social support. Yeah.
Yes. So you have to go. It's more. There's got to be more. And so that's why in the residency program, there's a lot more people that can serve. I have patients who attach themselves to me, which is because they see that I want to help them. So they connect with me that way. There's a lot more that needs to be done, and it's gonna take more. Yes, racism is there, lack of respect is there, but there's a lot more in it.
Yeah. Alicia, what do you see happening in your practice in addressing the social determinants of health that might be impacting birthing people?
One of the things that we like to do in our practice is, again, seeing everybody as a person and trying to provide that individualized care to every person that comes into our office. One of the things I enjoy doing is kind of looking at some quality, doing some audits and looking through our charts for any kind of racial disparities. What are we seeing there? And I think as a group, we just kind of are focused on getting rid of those deep-rooted beliefs. And we're all, advocates for policy changes and what we can do to help women out there and try to reduce these disparities.
So you're talking about like implicit bias and how
exactly
and how that affects
exactly
this population.
The stories. The American dream, when you look at these women and they come in and they're afraid to speak up, or they feel like no one listened to them. So those are things that we are really trying to overcome in our office.
Okay, great. I think we're going to open the floor to questions from participants. I'm sorry.
Yeah, I just want to say something really quick, and I promise this is quick. Sure. We also have to look at prevention. And when I say listen to women, it's not just about listening to them about their problems, even though that's a big part of it, but it's also listening, first of all, doing a physical assessment where you're touching a patient, doing a history where you're listening to the patient, you're listening to what they're saying, because a lot of times these women have signs and symptoms. They have things in their history, but they're often overlooked by their healthcare provider. So I think that's a big piece of it. Someone in the chat talked about having something about maternal health in their nursing program, or I can't remember, I know you'll talk about this, but I think it's important that implicit bias training, the history of the Black body in this country and the violations that happen, that's why there's distrust, but also learning how to do assessment on a person of color. So if somebody comes in, my pale looks different than someone who's white and pale. And if I'm pale and I know when someone tells me I look pale, I'm sick. So I think that it's so many important pieces to it. But I think it goes back to old-fashioned nursing care, medical care, where you're touching, you're assessing, you're doing a history. because not everyone just suddenly crashes. So you could teach someone how to handle postpartum hemorrhage, but how about those subtle signs that there's something going wrong?
Mhm.
So, and I think, I know you mentioned residents. Residents need a lot of support and education on how to care for women who are pregnant, because there's a lot of disrespect there. I had a nursing student tell me that 3 residents checked the patient and they still couldn't figure out how many centimeters dilated she was. That's a problem.
I would like to make a statement about some of the things that are happening in Kentucky. And I think, Dr. Canty, you will appreciate this. Effective October 2022, every nurse in the state will need to take a mandatory course on implicit bias, as well as a mandatory course on preventing nurse suicide. And one of the things that struck me about the video, the documentary, was implicit bias that I could feel. Kind of like what Alicia was talking about, is that this implicit bias, many people don't even know that they have it. And so their behavior and their treatment is not conscious. It's just not conscious. And so this implicit bias training should help. My question would be, is there something like that that's going to happen for physicians in the state of Kentucky? Dr. White, can you give me any insight into that?
Well, I can't give you any insight as far as Kentucky Medical Association goes, but one initiative that we are right now in the Kentucky Perinatal Quality Collaborative, we're working on screening women for substance use disorder, since that's the #1 cause of death of pregnant women in the state of Kentucky. But the next initiative that I'm not the whole steering committee, but I'm going to try to put as much sway as I can into it, is a birth equity initiative. We have friends in California where they're doing that birth equity initiative, where they are doing implicit bias training for the whole labor and delivery unit. And what I would like to see is that it not be a law that comes down from Frankfurt, but that it is presented to labor and delivery as this is a quality improvement. This is going to make your outcomes for your mamas and your babies better. And every nurse, and I hope every doctor, is going to sign up for that. In fact, and real quick, when they launched this in California, they had a big meeting, and there were a lot of people there that didn't want to be there because it is a law in California. And the first thing they did was break the group up into 3 groups. And they said, we're going to give each of you a case, and we want you to look at the case and come up with a treatment plan. So they all did, and they all turned their treatment plans back in. And they said, oh, we forgot to tell you that medical case that we presented to the 3 of you, it's the same case, except the first group was told this woman was white, and the second group was told this woman was black, and the third group was told this woman was Hispanic. And they came up with 3 different treatment plans. Absolutely. And when they told the group that, my friend Dr. LaGrue said you could hear this audible gasp, this aha moment of people didn't think they were biased, but that implicitness about it was front and center to them. Is we have to do better for these women. They deserve us doing better by them. So I'm hopeful that we can get a birth equity initiative in our perinatal quality collaborative, and we can recruit all of our birthing hospitals to participate in that. That's one of my huge goals.
That's important. Yeah, that's important.
That sounds very exciting. There's a comment here. We have to see people as people, not as brown, black, white people, or a person of a specific religion, especially everyone should be treated equally. I would just like to add one thing to that. What if everybody doesn't need that equal, but what they need is equity? Mm-hmm. Equal and equity are not the same thing.
That's right.
Equity is giving people what they need, not what everybody else is getting. Let's see, another one. We can learn to listen and respect even if we don't have time to get to know them in depth. Mm-hmm. Very kind comment. And then more and more, I think the role of the care navigator is critical, someone who knows the patient and their situation and who can advocate and help guide them through whatever they're going through in their healthcare journey. There's also the MCH outcomes. There's a link here from Dr. Eva Stone, I think. And what is the reaction of nurses who work in hospitals, labor and deliver, to this film? Is anybody a person who works in labor and delivery in a hospital that watched this film?
I saw a lot of me in many of the characters, and I thought that was I thought it was so great that I posted it on Facebook, so that people can see that I'm support it, and I'm going to try to post it in other places. I have countless stories of people, of what happens to them, and that film really, none of these women died. So that's the main important story about this video. Other stories you see, it's the family members are speaking because the women died. So that was one of the big things that I noticed. None of the women died. They noticed their experience. They did not like the experience they had at certain places, and they made a decision to go somewhere else to get care. And that's part of empowerment. And so that was a American dream to me.
One of the things I noticed was that the women heard things that maybe we don't think they hear. Mm-hmm. We say them and we may think it's a joke, or we just think we're only the people we work with can hear what we're saying. But women hear those things, and it really impacts their experience. One thing that stuck out was the one woman who said that her provider came in and said, "Is that your child?" And she said, "No, I'm babysitting." And they said, "Well, get ready to babysit for the rest of your life because you're pregnant." I mean, we need to watch those things that we say. Definitely. Any other questions that you saw?
No, there are lots of really great comments about the speakers and their responses. There's one here that says, "I just love Dr. White." That is just so cool. Dr. White, I do have one comment about what helped with those three groups. Do you think that if those three groups had implicit bias training, they may have been a little bit more aware of where they each could be and maybe thinking differently? Do you think that could have been of some help?
Yes, and I think that was their whole point. They wanted to start these people out at the very beginning who said, "It's not me.
Not me." I've heard that so many times.
I don't do that. That's and so right off the bat, the very first thing they showed them, yeah, it is you. It's not you're not accusing them or being trying to be difficult. It's just we all have biases, whether we understand them or not. And so, it's there. You can deny it, but it was very plain to everybody in that room that they had work to do. And so they've really dug into this, the Birth Equity Initiative in California, that again, we've been told that because we're public health, we can borrow shamelessly, and we plan to take everything they got and put Kentucky on it. They said we could, but so we're gonna start that initiative.
You're absolutely right.
Yes.
Cristin Whitaker has raised her hand. We only have 5 minutes left, but Cristin, if you'd like to ask your question, we'd like to hear you.
Well, I wanted to give if there was any active labor and delivery nurses a chance to answer that question, but I used to work in labor and delivery, and I'm now a nursing instructor. And one of the reasons I wanted to come to be a nursing instructor is around this issue. And my initial reaction to watching this video was I could see the trees, and it reminded me of my childhood growing up in Florida. And then I recognized that they were in Florida. And I think just all my life experiences kind of culminate to this. And I just kept hearing this theme of worthiness. Either the people they didn't feel that they were worthy of being mothers. And I think we pass that judgment on, and that's where that unconscious bias comes in. And myself, I struggled with infertility while I was working in the labor and delivery unit. And I remember having these feelings of why them, why not me? They are not worthy. And that worthiness aspect, I feel like we really have to just check that at the door when we come into work. And that was the biggest, hardest lesson I think I had to learn. But I'm grateful of those life experiences that we need to think about how, when we treat people, how we're giving them that message of whether they're worthy or not to be a mother, and that approach to it. So that's how.
Thank you so much for sharing. Yes. That was very, very kind. I really, really appreciate it. Teresa, at this point, would you like to talk about our next social justice movie night, and then we can let Donna close us out?
Our next social justice movie night will be on April 21st. We have not settled on a topic yet, but it might be the disparities we are seeing in chronic kidney disease. Chronic kidney disease, as you well know, costs this country a lot of money. There's a lot of people that have chronic kidney disease. A large portion of those, around 40%, are people of color, even though people of color only make up about 13% of our general population. So there are big disparities in that. April 21st from 6 to 8 will be our next Social Justice Movie Night, and I hope you all come. I want to thank our panelists. This has been, again, a very rich and thought-provoking discussion, as they all have been. So you all have been wonderful, and I appreciate you giving your time to our discussion tonight.
But I want to thank you guys all so much for joining us tonight. I'm just absolutely amazed that we had 103 or more people on this call tonight on a Thursday evening in your personal time. But what a important topic. And thank you so much to all of our panelists from all across the country, and right here, experts in our own state. So thank you all so much for joining us tonight. This was excellent. And hopefully you all will be able to join us on April 21st for our next Social Justice Movie Night. And we can improve social justice and continue that in Kentucky through nurses. So thanks a lot.
Thank you.